Paul will be presenting from our Seattle Children's PT team. He's a sports physical therapist with an emphasis on whole body movement, pattern assessment, and correction. Part of the group that published novel interval throwing programs specific to age and field size. Began career working with PT clinic focused on Little League elbow, as well as a lifelong baseball fan. And then Dr. Daryl Osbar will be presenting after Paul. He is an internationally renowned orthopedic sports medicine surgeon that serves as chief of orthopedic surgery and managing director for Rothman Orthopedic Institute, Florida, and the executive medical director for Advent Health Orthopedic Institute in Florida. He currently serves as one of the co-chief medical officers for USA Baseball, as well as a team physician for the U.S. Soccer men's national team and World Wrestling Entertainment. He has been recently serving as chief medical officer and head orthopedic team physician of the Orlando City Soccer Club, as well as an orthopedic consultant for the Professional Golf Association, Ladies Professional Golf Association, and Symetra Tours. A native of Florida, Dr. Osborne performed his orthopedic and sports medicine training at some of the most prestigious institutions in the world. He completed his orthopedic sports medicine fellowship at the American Sports Medicine Institute in Birmingham, Alabama, a premier sports medicine program under the guidance of Dr. James Andrews that treats internationally recognized professional athletes. He completed his orthopedic surgery residency at Hospital for Special Surgery in New York City and his internship in general surgery at Weill Medical College of Cornell University at the New York Presbyterian Hospital in New York City. He earned his MD and undergraduate degree from the University of North Carolina in Chapel Hill. In addition, Dr. Osbar is intricately involved in national and local educational initiatives dealing with the prevention of youth and adult sports injuries, including serving on the USA Baseball Medical and Safety Committee, as well as the former chair for the Education and Outreach Committee for the nationally recognized Stop Sports Injuries campaign. Within the state of Florida, Dr. Osbar also works on a grassroots level to advocate for safety and prevention of youth athletes through his role as former president and current board of directors for the Florida Alliance for Sports Medicine, committee member of the Florida High School Athletic Association, Sports Medicine Advisory Committee, as well as the Medical and Safety Committee member and advisory board member of the Sunshine State Athletic Conference. So Paul and Dr. Osbar, thank you so much. And Paul, the floor is yours. And Paul, you might be double muted.
We're good now?
Now we can hear you. Yep.
All right. Well, thanks for having me. What a great panel to be a part of. One of my favorite topics to talk about. Baseball is just a fun sport. There's a lot of information, a lot of data. I grew up kind of nerding out on, my uncle got me this baseball almanac that was about 8 inches thick, right, pre-internet days, had every statistic of every Major League Baseball player since about the 1960s, or 1860s, I should say. And I would just comb over that as a kid, not realizing that that would help me in my later days when I would be looking at research instead of looking at batting average and RBIs, be looking at kinematics of the elbow and the shoulder. It was a great topic. Steve Cisco probably loves baseball as much as me, but unfortunately he's in Hawaii on the beach right now. So you can send him your condolences for missing this. Let's see if it'll move. Whoop. There it goes. So be kind of intentionally broad with this. So I'm talking about rehabbing an injured baseball player. Obviously, there's a lot of different injuries you can have. Primarily, you're going to see your elbows and your shoulders, right? Medial elbow and shoulder pain. So just going through, talk about what is throwing, how do we kind of define that? What's the risk of injury for these throwers in general, right? So if you play baseball, if you play softball, what's your risk just inherently being in that sport? What are kind of the stats on who gets hurt, where they get hurt, how often? So then reviewed today in good detail from Dr. Oliver and the Driveline guys. We'll just kind of do a quick review on throwing mechanics. So your kind of typical errors you're going to see when you're seeing these patients that are coming to you already injured. What do you look for? What do you tend to see? What do we do with them? What kind of exercises are we looking at? You know, I think we all know the typical seated external rotation drills, things like that. Kind of getting that whole body view is pretty important to these players, as it was kind of laid out by Devin and Terry. And then preparing for your interval throwing program. Crucial piece that we use at Seattle Children's to get them back to throwing. They are injured when they come to you. They probably have pain with throwing, or they just had surgery, they can't throw. How do we get them back there safely? What's the timing? How do we get them there? How do we educate them on getting back to throwing, 100% safely? And other considerations, talk a little bit about the pitch smart that Devin and Terry were talking a bit about earlier. Warming up to throw, not throwing to warm up. Big thing you'll see in players. It's probably less sort of rampant nowadays. I think it's sort of cross threshold where most coaches are aware of this. The kids do at least some running, if not some whole body drills. But a lot of kids go out there, it's 36 degrees. They've been sitting in school all day or something. They grab the baseball and they start hucking it. Chances are mechanics aren't great. Their tissues are not warmed up. That's a good chance to increase injury. And then just kind of the risk level, again, as a thrower. Obviously, injury type is going to play a role in your rehab. Is it elbow? Is it shoulder? Is there a loss of motion, right? Do we lose external rotation? Do we need to work on those kind of local things? And then post-op versus non-op. So throwing, how do we define throwing? Some of the things in the literature, one of the fastest known human movements. I think that's really helpful to be aware of, right? This is a high octane thing. That's a lot of stress on the body. So about 7,000 degrees per second the arm can be going. This is, your higher level pro guys, and up to 1,200 RPMs, which is about equivalent to an engine on cruise control going 50 miles an hour. Again, high octane. Another thing I like, summation of forces beginning from the legs, translate through the middle of the body, and then to the fingers, right? This is energy transfer. This is, creating energy to the bottom half, transferring it all the way to the fingers through the middle of the body. Precisely timed and balanced neuromuscular coactivation of almost every muscle in the whole body. Really going to highlight this today. It's really easy to get enamored with the arm, right? External rotation, scapula, rotator cuff. Looking at what's happening way down at the hips, even ankles, can be really helpful in enlightening your understanding of how that player is throwing a baseball. And again, just highlighting the legs, they contribute about half of the power to throwing, right? This is a major piece of the puzzle. Ben Taylor does great research on kind of scapula. He figured out that about a 20% decrease in kinetic forces from the legs sort of makes you overdo it at your arm by 34%, right? So it's not just a one-for-one comparison, a little less legs, a little more arm, a little less legs, a lot more arm, right? We see this a lot in our throwers coming to you with arm pain. Look at their legs. Are they not using their legs? If they're not using their legs, then it doesn't matter what you do with the arm. You can make their external rotators as strong as possible. They're probably have sort of excessive forces going through there. Rotational torque, hip shoulder separation. Terry and Devin talked a lot about this. It comes up again and again in literature as being important to velocity, which of course your player is going to care about, and injury prevention. So huge thing that they get that sort of transverse plane twist. This is very much a twisting rotational sport. So some of that inherent risk on throwers, they've done cadaver studies where they take the UCL, clamp it down on each side, pull it apart, and measure at what force it ruptures. So around 34 Newton meters from what I saw. The torque from throwing higher than that in high school players, right? This isn't pros. It's up in the 40s for high school players. So obviously what's going to prevent you from snapping your UCL every single throw? Your active stabilizers, dynamic stabilizers for our muscles, et cetera. So the control of the arm is a big deal. It's not a huge ligament in the arm when you're doing thousands of throws every week. You got to make sure you have those muscles doing everything they need to be doing. Volume, huge thing. Talked about this today before. How many games do you have per week? How many practices? Are you playing on 2 teams? A lot of players you're going to see play for their high school team and their traveling team. And they're having seasons go on at the same time. Is there a pitch count? Do they actually adhere to the pitch counts? There's different ages. We'll talk a little bit more about this later on, but different ages, kind of USA Baseball has these, rough pitch counts that you should adhere to. Do they actually stick to it. Early sports specialization just got brought up. Another big thing, are they 8 and they only play baseball and they don't do anything else? They don't go to driveline. They just play a lot of baseball and throw the ball a lot. Obviously, you need to take that into account when you're rehabbing them. You know, if you just send them a few exercises, get them pain-free, send them on their way, now there's a good chance they're going to be back in your clinic, right? Huge thing is increased throwing velocity. This is a risk as a thrower, right? What makes you throw harder? Older, you're higher, you're taller, you weigh more, right? You're bigger. Those things we can't control. They're going to want to be throwing harder, obviously. The older you get, it will kind of naturally come. Things we can control, that hip-shoulder separation, which we'll check out some videos later. Stride length, huge one. You'll see this a lot, and especially the younger crowd. It tends to be better as you get older towards the high schoolers. You get that about 85% of your height is what the research shows about what you want as a pitcher. It's a long stride, right? If you're not doing that, you're lacking some force in your legs, which, as we talked about, can lead to some sort of catch-up extra forces on the arm. One study showed about 3/4 of high school pitchers that had ulnar collateral tears throw over 80 miles an hour, right? So it's just a risk. You just have to be aware of that. Your bigger, older players that throw hard, even if their mechanics are great, are just at a higher risk. Mechanics talked a lot about this today as far as the driveline guys. Did a great job going over this stuff. Kind of varies with their research. Who is looking at it? One study showed that if the coach sort of assesses, oh, the mechanics aren't great, it doesn't show an increased injury risk. So I think it kind of depends on who's looking at it, how you're assessing it. You know, like we talked about, there's variability in this stuff. How you throw a baseball can be very different. So it's thought to be very important, and you're going to work on it. But just know that there's some variance in who looks at it and who thinks it's bad, who thinks it's good. We do think that it helps maximize performance, right? Curveball, another kind of point of debate a little bit. What I think the consensus mostly is that probably the later you start, the better. If you're, 10 years old throwing a curveball, there's probably more stress on the elbow. There's been some studies that show that. It's been recommended, I think USA Baseball says around 14 is what you want to start with a curveball. The straight balls, the fastballs, the change-ups where you don't have that big torque or twist of the forearm, probably a little less risky. So it's kind of a point of contention. And then playing both pitcher and catcher, big one. You'll see, what positions do you play? You got to ask them that. Sometimes it's just a position player. Almost always they're going to play pitcher. Sometimes they also play catcher, sometimes in the same game, right? So they're throwing, okay, I had my pitch count, I stopped at 75, and then I played catcher for 4 innings. Well, the catcher throws the ball back to the pitcher every single time. They're going to throw hard to second base, catch runners. So that's a lot of extra throws after potentially they're already fatigued. Another risk, over 100 innings for a youth player increases risk of not just injury, but potentially surgery, serious injuries, by about 3.5 times. So volume, big deal. Again, that lower body deficit, 85% of height for stride length. We talked about that. Great study. UCL tears, patients that had that tend to do worse on the lower body Y balance test, right? That dynamic balance, being able to control your legs over a great, range of motion, a big excursion. That control from the bottom half probably helps decrease the risk for getting injuries in your upper half. We all know about the shoulder rotation. That's been studied extensively. Lack of internal rotation, if it's coupled with external rotation gain, that's probably a structural change that the body's developed, especially if they're a bit older, teenage youth, especially. That's if they've been playing since they were 5 and throwing a baseball thousands and thousands of times, the structure of the body has probably changed to allow for that external rotation gain. As long as the total rotation is about the same, you're okay there, but you got to measure both. Obviously, shoulder strength, rotator cuff, scapula, really big deal. And just the best time to achieve good throw mechanics is young as possible, right? It's going to be harder if they've been playing for years and years with these altered mechanics. So if you get that 10-year-old that has pain, you got a good chance to change how he's going to throw that baseball, how she's going to throw that baseball. So some research shows that your 9 to 12-year-olds get elbow pain, about 20, 40% of them. This is a good chunk, right? I mean, a baseball team's going to have probably somewhere in the teens players, let's say 15 players, 17 players, something like that. 20 to 40%, you're talking multiple players on every team potentially are going to have elbow pain with throwing. A lot of them at that age are going to have normal radiographs. You're not going to pick up anything. It's that kind of standard little league elbow. Difference between that apophysis versus UCL, skeletal maturity. What's the weak link? If that apophysis is not closed, then you're looking at little league elbow that has potentially more UCL. Around half or so pitchers get shoulder elbow pain at some point during the year, right? You're not going to see all of them, but again, I mean, you have a team of 15 players. You're looking at several of them at some point are going to have some sort of pain. Maybe not significant enough to see you, but this is common. You're gonna hurt probably. So just a couple of things on joint mechanics. Consists of motion, a sequence of motions that start when the pitcher lifts the lead leg, progresses to a link motion of the hips, trunk, culminates with a ballistic motion of the upper extremities to propel the ball towards home plate. So, right, whole body motion. Starts from bottom, goes to the fingertips. Steve, want to add this? So there's no two pitchers that throw the exact same way. It's an art and a science. Everybody's body is different. And everyone reacts to stresses differently, allowing great variability in the throwing process. But science tells us some movements and positions put more stress on the body. So, right, let's not be nitpicky. We'll look at how they throw. Kind of talked about this a little bit earlier. It's okay if there's some variability. There's some major things you're looking for, right? The stride length, the hip shoulder, rotation, separation, some major themes that you want to see, and some variability within that is probably okay. So I love this graphic. So this is kind of how I think of throwing, all right? You're creating energy at one end of the body, transferring it all the way through to the fingertips. If they're injured, you're looking for the leak in energy, right? Where is it coming from? Is it in the middle there? Is it the trunk? Is it the legs? Is it scapula? Are they stiff? Right? Do they just lack motion and they can't rotate through their hips? Just another little kind of visual, right? You're creating motion, you're transferring it through the middle of the body, culminates through the hand. I'm sure doing those sort of mechanics, right? They kind of separate in about 5 stages. At the wind up, cocking, early cocking, late cocking, basically arm comes back. Acceleration, arm comes forward. Deceleration, arm slows down. Follow through is just sort of everything that comes after that. So just reviewing those sort of mechanics. So study a while back that kind of gives some points of things to look for. Leading with the hips. So you get that wind up, they bring the knee up, they start leaning towards home plate, leaning towards the target. Hips should go first, right? This is loading up the upper body like a slingshot or a bow and arrow to get ready to propel towards home plate. You got to go back before you go forward. Hand on top. You sometimes use younger players, generally not the middle school, high school age. Right, this is usually associated with kind of opening up early, sort of not loading the body as much. Hand on top of the ball. Arm throwing position. By the time the foot lands, the arm should be in maximum abduction, right? It's ready to come towards home plate. If it's down too far, there's going to be a sort of catch-up motion when you get this back and forth. Again, at stride foot contact, that front foot comes down, closed shoulder, right? So on the left number, or A, shoulder is still closed towards home plate, turning towards third. He's getting ready to whip his body around, rotate towards home plate. If you're open, what do you have left to throw with B? His arm, basically, right? He's got no force to pull himself through with his abdominals, hips, etc. And then you watch that stride foot on the left, right towards home plate. The one on the right, he's opening up way too early. By the time that front foot hits, you're talking about 0.145 seconds before the ball comes out. Okay, this is a ballistic, powerful motion. So if you're at that point in the patient, you got to get video. I mean, we have great, high definition, slow motion cameras and iPads and all that. So you got to be able to slow it down to really see what's going on. By the time I'm throwing, this should be pain-free. Let's see if this will work okay here. Maybe. Oops. Is it going to work? Okay. Okay. There we go. So wind up. So, right, leads with the hips. Stride foot, arm throwing position, slingshot it forward, follow all the way through. right? Know how far down his trunk comes. This is Roger Clemens, famous pitcher, one of the best pitchers of kind of 80s, 90s, pitched for like 20 years, threw 100 miles an hour. So just kind of classically great mechanics, really uses the whole body. What we got here? Oops. There we go. Okay. And not sure if these videos are going to work here. Okay, well, let's try this one. So some examples of some kids in clinic. Pretty choppy. Looks like that's not really working. All right, we will bail on that. Point I was trying to illustrate with these ones, these kids, they weren't throwing 100%, right? They were just doing some throws against the wall. Each time you can kind of see the girl on the right, pretty upright, pretty short step. Hard to see in the still frame, but no hip shoulder separation, right? Her whole trunk comes forward at a block. So she's not translating that energy from her legs, loading up her torso, whipping that ball forward with her body. She's got nothing to throw with but her arm, right? She can't use her trunk to pull that ball forward. So she's kind of not using her whole body. Let's get that here. Whoops. So in your assessment, looking at the victim versus the culprit, right? Obviously, they're coming to you with pain, right? They have elbow pain, they have shoulder pain, they cannot throw. There's not a great reason to focus on that location of pain. There's going to be some local stuff you got to work on. You got to do your soft tissue, you got to, get back external rotation, whatever you need to do locally. Figure out what's the culprit, right? This is a throwing injury. I was trying to show with those videos that didn't work. What body parts are sort of lacking or not contributing to the throwing motion that could potentially be adding more stress to the arm? So, example, medial elbow pain, poor hip shoulder separation in your throwing assessment, coupled with weak obliques and scapula and glutes, right? So all these muscles in the middle of the body that help twist you forward, they're lacking strength there, right? So link those two things together, work on those things. You gotta look at the whole body, head to toe. It's really easy to miss hip stuff, right? Everyone wants to catch the rotator cuff, scapula, maybe even thoracic rotation. You're gonna miss hip stuff if you're not looking for it, right? If you have them stand with their feet together, twist to the right, twist to the left, they twist their shoulders there. If they can't separate their hips and shoulders in standing, they're not gonna do it when they're throwing a baseball or softball. So you gotta be looking at these things. Typical things you're gonna see, your balance deficit, right? Standing one foot potentially, but dynamic balance, like that study showed with the Y balance test. Scapular dyskinesia is a very, very common one. Scapula is all over the place, so is their arm, right? That's an energy leak. They're pushing out their legs, they're trying to throw a baseball or a softball from their fingers. Scapula is not translating that energy. You got to have that makeup force at the arm, like that study shows. Decreased hip mobility. So kind of everything, right? But a major thing you'll see, you want that external rotation to the lead legs, kind of twisting, reaching out for home plate, and that IR or extension from the trail leg. Gotta have that push off, right? You got to be able to launch your body forward, get that long 85% stride length. If they have stiffness in their hips, you can cue them all you want. They're not going to be able to push off the mound, right? They're not going to be able to get that full hip extension and launch their body forward. Glute strength and power, really common one with players. It's just kind of visual representation of the things you're thinking about with a baseball player, right? You got to balance all these balls at the same time. You can't focus on one and not the other. And the size of the problem or issue could be bigger in different players. So you have to do your assessment, figure out, what am I focusing on? This player, for example, throwing volume might not be a big issue. Play for one team, they have their pitch counts. They're not overthrowing. Their mechanics are pretty decent. Maybe they only play baseball. Maybe you're not conversation about cross training. Maybe doing some weight training, playing other sports. Maybe a big thing is they have scapular dyskinesia and their core strength is terrible, right? That might be your main thing you're working on. Another player, cross training might be a really, really big deal. They might be playing for two teams. They're not really abiding by pitch counts. They're throwing way too much. Might be a big patient education case, right? You're going to work on your strength and whatever you're doing. but they might need to have serious talk with them, the parents, maybe talk with the coaches about throwing volume and getting that in balance. So just visual representation of, you got to balance all the balls at the same time. Some are going to be more important or bigger deals to each patient than others. So some common errors with throwing problems. Can't emphasize this enough. Don't treat off a single data point. Right? You can watch them. You can go, okay, I'm excited to watch them throw. You pick apart their mechanics and go, all right, do this, right? And so they're like, what? How do I do that? So you see them, for example, shorten stride length. We'll couple that with their physical exam, right? Maybe they have really tight and shortened hamstrings. They can't touch their toes. Their hip flexion is limited. They can't physically give you a long stride because they don't have it. So cueing or doing some drill to get them to stride out farther when they throw might be, a waste of time versus just building up that basic mobility from the ground up first. For example, poor hip shoulder separation. Can they rotate through their hips and their trunk, right? If they have a super stiff T-spine, you can't cue them to rotate through their trunk more. You're going to have to build that from the ground up, do some drills, exercises, manual therapy, whatever it may be, to actually get them that basic amount first. Then we can cue them, work on that with throwing. Again, poor follow through, poor trunk flexion. You'll see this a lot with players. So I was trying to show with those videos earlier that didn't quite work. Unless it's Max Scherzer, great player. He's almost scratching the ground with his fingertips, right? So he's coming down far. If they look like the kid on the right, you're not going to cue them to look more like on the left, right? They're not going to be able to pull themselves down because they don't physically have the mobility. You might have to work on that in a basic way first, right? Then build them up with their throwing mechanics. So you treat your local and your global impairments, right? So whatever you need at the elbow, the shoulder, and then you look at the physical assessment and work through those things. Throwing mechanics, this might be a necessary point too. This is sort of, in part can be almost like a behavior, right? They've thrown the same way since they were 6 or whatever, and they just need to retrain their brain to throw differently. There's some great drills that Steve and a couple of guys made and put on SharePoint that you can access. Posture is another big thing. If you treat this 13-year-old kid that's looking at his phone all day, slumped over in his chair at school for 10 hours a day, and then he goes to the baseball field and expects his T-spine to operate properly, good luck, right? It's not going to happen. We have to get some education there. And they tend to listen when you couple it to, this is making you a worse baseball player, right? But I love to pull that lever. It's like, okay, you're here because your arm hurts, but your posture is making you throw less hard, or it's making you a worse baseball player. However you want to word it, motivating them in that way. They tend to listen more than mom's on set, right? Education, throwing volume, right? So this is all the things you're working on at the same time. Again, those bubbles might be a little bigger depending on the patient. Warm up the whole body. Warm up to throw. Don't throw to warm up. So again, a kind of a whole body dynamic warm up is thought of to be ideal. And then your cross training, right? If they're, say high school age, they haven't lifted a weight in their life, that might be a conversation you need to have. It's like, hey, if you want to keep playing baseball, if you want to keep pitching, there's big stresses. You need to train your body, kind of what the drive-on guys were talking about. So just a couple of examples of the random selection of exercises that Steve and I kind of picked out, by no means complete, but a couple of ideas. Poor hip shoulder separation, poor thoracic rotation. Example of an exercise you can do. They're stabilizing their trunk, their scapulas are pinned to the ground, and they're getting that rotation. Chop and lift, classic sort of transverse plane trunk stability. Super light bulb moment sometimes for those kids that don't control rotation. Get them on one knee, get a band or something like that. Okay, pull this down to your hip, and they get blue in the face and they fall over. Why is that so hard? Well, this is probably why you hurt yourself. You don't control rotation very well, so you have nothing to throw with but your arm. A lot of these kids, you get a 10-year-old that has arm pain, it's a good chance they've never lifted a weight in their life. They don't know what a kettlebell looks like. They don't know what a deadlift is. Just get them that baseline body strength. Again, starting from the ground up. This is where the throw starts. Glute strength, so single leg deadlifts, double leg deadlifts. And then some of those kind of whole body mechanics exercises, these are great things to work on when they're not yet ready to throw, but you want to have them put it all together, right? And do movements that sort of mimic the demands of throwing without placing stresses on the elbow or shoulder. World's greatest stretch, shout out to Kyle on that one. This is one of his favorite exercises. Great way to get that rotation through everything, through the whole body. Just balance, you're coming down, you're twisting, reaching, right, thoracic mobility, hip rotation, core stability. Lawnmower Lunge, another great one, right? You're holding some small dumbbells up at your ears, you lunge forward, reach across your body, get that twisting motion, and then eccentrically control that, pull it back, right? Get that sort of rebound, work on those muscles on the backside of the body that are going to slow your arm down. Rebounder throws are great. Collecting yourself, getting power off that back leg, and turning and translating that through your fingertips, right? This is what a throw is, basically. It doesn't have the demands on the arm like throwing overhead would be. It's more of a chest pass. Similar exercise, ball slam, same idea. You're getting the transverse plane, you're loading up, you're slamming down, you're pulling down. You can't pull this down with your arms, right? You get those sort of classic arm throwers that they don't pull down, they're all here, they can't pull themselves down. Try to slam down a heavy ball with that. It's not going to be loud, it's not going to be real hard. So getting them to figure out how to powerfully use their body in those kind of rotation motions. Kids that have poor stride length that need that hip power, bounding straight, lateral bounding, your height and jumps kind of left to right. Great drill. You'll see kids fall all over the place. They can't do this. They don't use their legs for throwing. Again, it's one of those light bulb moments. Like, why is this so hard? Like, well, your body doesn't control these motions from the ground up, right? So that's why you're sort of leaving your arm out to dry. A couple of my personal favorites with throwers, Turkish get up. You have to be stable and mobile throughout the whole body to do a Turkish get up. Another one where we see kids just absolutely struggle. They do one and they want to take a 10-minute break and get some water. You're like, no, we're going to do like 5. I'm like, oh my gosh. Right, there's rotation, there's weight bearing stability through the upper body, hip mobility, kind of all the way through. Kettlebell swings, another great one. Generating power from the hips, stiffening and sort of translating that energy through your trunk, stabilizing the scapula while you get some arm motion. Great drill for throwers, especially single arm. So getting to your interval throwing program, they've got to be pain-free, right? There's no sense getting back to throwing if they still have some pain. They get a special test. Obviously, there's your protocol, timeline considerations. If they've had surgery, you need to follow that. You got to see these improved impairments, right? If they're sort of victim versus culprit, right? Their culprits are X, Y, and Z, and X, Y, and Z, not much better. You might need to work on that a little bit longer before getting back to throwing, because chances are they're going to go back to their old habits with throwing if you haven't improved their glute strength, if you haven't improved their sort of core rotational control. Get your slow-mo camera out, check them out throwing, and then throwing drills. Steve's a big fan of these, like throwing with a towel, just going through the motion, right? Getting those mechanics down, using bands to help train whatever it is that you're working on. And then once you get it back to throwing, you got your general throwing base off field size. So this is what we developed at Children's a couple of years back. Are they 60, 70, 80, or 90 foot bases? That determines how far and how much they throw. And then if they're a pitcher or catcher, they have a second one in addition to that. They're going to get back to those specific positions since there's greater demand for throwing. Just a quick example of that, right? There's about 7 days. You take a day off in between. It'll tell you exactly how many throws, exactly what distance, and on the left, exactly what to do if you have pain or problems. You take your day off, you try it again the next time. It usually goes pretty well. And kids are pretty independent. By that time, they're dying to get back on the field, right? So you don't have to convince them to throw a baseball. Last thing, Devin and Terry alluded to this before. Pitch Smart was just these USA Baseball, Little League Baseball, Major League Baseball kind of came together just to get some recommendations for easy use players, since as you know, the rate of injuries is pretty high. So just, these guys have done the research. They're giving me some ideas on how to go about training and preventing injury. So, Glenn Fleisig, James Andrews, all these guys. Main takeaway, take time off from throwing, right? if the pros don't pitch 12 months a year, your 10-year-old probably shouldn't either, right? I think what they recommend is 2 to 3 months continuous, ideally 4 total. Play other sports, do other things, right? That was reviewed earlier. So just a couple things they talked about. Relationship between pitch velocity, performance, and injury. Kind of read through that. Basically, so the high velocity is, it's going to attract the scouts. So if they really want to play in college or pros, velocity is a really big thing. Not a huge correlation between velocity and performance. Shout out to Jimmy Moore, if anybody remembers the 90s baseball pitcher for the Mariners. His fastball was like 84, right? Just slow for major league pitcher. And he had about 8 different changeups where he could throw it down to like 60 miles an hour, and he had players falling over themselves trying to hit. Right, so just an example of a guy that did not have a lot of speed but had a ton of skill, well-rounded athlete. So working on kind of the whole body, not necessarily obsessing over velocity, and just being a well-rounded player is kind of helpful. And same thing with the weighted ball programs they talk about. May lead to increased pitch velocity, but possibly increase the risk of injury. Jury's still kind of out in this one. Obviously, Devin and Terry went over this earlier. But just caution with that, right? So if you have people that have data that are doing it in an appropriate way, using that tool appropriately, like Driveline, you might be okay. Some people may not. Some may buy them off Amazon and go, all right, son, let's go huck this ball against the wall. So just be aware this is a thing. You're going to have players that are talking about this and using it. Not going to go through this whole thing. Just again, general guidelines from PitchSmart. Whole body movements, closed chain things, multi-joint movements are really, really helpful. Again, if you're just doing seated external rotation, you're going to miss some big things from the body. Hip motions, pull to press ratio, the big one they recommend 2 to 1, or even 3 to 1 in the off season. More pull exercises, your rows, your lat pull downs versus your bench press, chest press, biceps curls, things like that. Get your 15-year-old boy that is not guided in the weight room. There's a good chance of doing too many curls, too much bench press. Might be a conversation you need to have. I'm running short on time, so I'll wrap this up here. So this is a steep slide. So you want to make sure you got some great motivational quotes from Kobe Bryant to Yoda. And then lastly, just kind of sum it up. Know that every player is going to have a different size of different slices of the pie that you need to work on, but you want to look at everything, right? Your local stuff, your mechanics, your strength from head to toe, all these things at the same time, and just balancing out what you're working on with that player to get them back. And that is all.
Thank you, Paul. That was wonderful. Dr. Osbar, if you would like to share your screen, we can jump right into your presentation before the Q&A at the end.
All right, am I sharing?
It looks like you're sharing the folder that the PowerPoint was in.
How about now?
You might need to still the folder and not the PowerPoint.
Okay, 1 second. So I'm going to go back to share. All right, now can you see it?
Yes, now we can. Thank you.
Okay. All right. Well, thank you. Thank you so much for inviting me. So I can go ahead and just get into it.
Yes, please.
All right, perfect. So today, having the pleasure of talking about throwing injuries. Obviously, this talk could probably be a couple hours, and if anybody knows me, I would use up a couple hours in talking. So, just going to try to go over some introductory goals from a presentation perspective about phases, arm care, some of the evaluation techniques, including the exam, and then a couple specific throwing shoulder and throwing elbow injuries. And so this is the main thing I think about with throwers is we have to take great caution whenever we treat them. The fact is when managing all throwing athletes, we really need to understand all the factors that go into to a thrower and properly preventing injury, recognizing the problems. And some of those problems are actually adaptive in nature, and then optimize return to play in a quick fashion with minimal intervention. And so obviously in a lot of ways, this can be non-surgical. And so the more you want to operate on a high level thrower, the more you can find yourself in a bad situation. So just to level set, these are the phases, obviously the throwing motion. The reason I point this out, this is one of the things that usually we have to get a good understanding of when they're experiencing pain, if it is during the throwing motion, of what phase, because some of these phases are more likely to cause symptoms with specific pathologies. For example, late cocking early acceleration can be more when it's an elbow. It can be a Tommy John ligament issue. More in the deceleration follow through when you're getting into relative extension, it can be posterior medial impingement. So just things to think about. When it comes down to throwing arm care, I think about these things whenever I'm seeing a player is, do they have the strength and balance? So is their gas tank empty? Obviously, with a lot of youth throwers, they're constantly using up the gas, but they're not replenishing, and a lot of them are weak. And so I like to get an assessment for that. Number two, biomechanics. Does the so-called engine fit in the car? And so do they have good mechanics to make a good throwing motion, or actually they throwing with their arm and generating strength with their arm, not using their lower body correctly? And then finally, overuse. What is that mileage when it comes down to the car? So is that athlete, been overused for a long period of time, or is it short period of time? So try to get a sense for that acute and chronic workload management issue, which obviously has taken up a lot of focus when it comes down to soccer and basketball these days, but not really baseball as much. So I know that a lot's been already talked about the kinetic chain. So I'm not going to go into depth on this. We've had a lot of great conversations by a lot of people that know a whole lot more than I do about the kinetic chain. But just as a reminder, it's so important to generate the strength with your lower body and transfer that strength to the upper arm in an effective way. And certainly, if you aren't able to transfer that strength from the lower body to the upper body, or you have a slow arm, then you're going to put increased stress on the arm as you try to increase velocity. So it's important to think about the whole kinetic chain. So when it comes down to the thrower's evaluation, history is extremely important, and it's important to get a sense for why the athlete's there to see you. How are they experiencing pain? How is it limiting them? And so you want to understand their injury history. I always tell a lot of throwers that they probably shouldn't be playing football during the course of a baseball season, because small little stresses in football can stun the rotator cuff, can make it be less efficient, and they're pitching in the same season. Often those small injuries can become bigger issues in baseball. And so it's important to understand, if this is a multi-sport athlete, how is that multi-sport athlete playing during the course of that season? And so understanding how the injury occurred, what sport it occurred in, and whether they're experiencing symptoms with baseball and it's just the symptoms are just occurring with that are important. Number two, duration. Try to get a sense of if it's acute on chronic, or chronic. What I'll tell you is most symptoms I see are either chronic with overuse, or they are acute on chronic, especially in baseball players. So often I feel this is a long developing problem that's occurred. I talked about before pain. What a throwing phase is it occurring with? It's important to get a sense for that. And then some of these symptoms that I'm describing below with the functional symptoms and associated symptoms are things that you don't always ask athletes in other sports. So what is their percent effort they're able to throw with before they experience symptoms? Are they losing velocity control? Do they feel like a dead arm? These are all the things that you want to start asking, especially in a thrower and a pitcher, as opposed to another athlete. And so when it comes down to the physical examination, after you get that history, we need to remember, as I talked about before with kinetic chain, and as many of you have heard from earlier conversations or presentations today, pitching is not an isolated upper extremity sport. So it's important to really examine the lower extremities, the trunk, and the scapulothoracic motion segments to see how are they doing. We don't always think of as baseball pitchers as ballerinas or gymnasts, and certainly John Lennon in this picture, who we had on the Nationals when I was with them, would never want to be called that. But they really are, and often that's that stress and also that strength and that control that they have to be able to utilize that strength in the right way and maintain and build velocity in their throw is important. And they have to have good balance, and they do it. Now, listen, every once in a while we get an athlete like Levon Hernandez. Anybody that knew him, you could not get him to lose weight. You could not get him to get in shape. And always what he'd say is that My cousin, El Duque, he's fit, strong, always hurt. Me, leave me alone. I'm fine. So we always got to have to remember in the back of our head, even though you do the right thing on an athlete, doesn't mean you'll keep them healthy. And even though you do the athlete or the assistants around them does the wrong things, doesn't mean necessarily they're going to get hurt. So you can always have those situations where it's not always and never. So getting down to the rest of the physical exam, you want to focus on the scapula. Is it dyskinetic? Is it winged? How does it move? Also, how does it function during the throwing motion is extremely important. So it's important to get a sense for how the scapula is positioning, because the rest of the arm is working off of the scapulothoracic segment. And then you can go into more of the shoulder exam. With the shoulder exam, often I sit there, and especially with our young kids, all of them have poor posture. And I always tell parents the posture is not just related to his low back and the hunching that somebody has, but it's also how are their shoulders positioned? Are they sitting in a protracted or retracted situation? Because obviously, if you sit protracted all day playing video games, watching TV, not with good posture, then you're just letting those scapulothoracic and those rotator cuff muscles get weak. And certainly that can make the front tight and the back weak. And that is not good for a thrower. So I tell my son every day that if he wants to be a soccer player, he can do that, but not from a baseball perspective. And so the throwing motion exam is important too. Just remember that the motion is not the same as the contralateral side. Typically, they'll have less internal rotation on that side, and external rotation can be variable. Often we'll see people with a little bit more tilted external rotation, but often we can find that both loss of internal rotation and excessive external rotation can be issues for throwers. And a lot of that's adaptive in nature over time. I didn't want to go into a lot of the adaptive pathology, but really you can have glenoid version and humeral head version as young kids that gets developed. And then sometimes once you start developing more retroversion, that can change your range of motion arc, but also can put increased tension and stress on tissues over time. The rotator cuff testing is important, not just in the normal rotator cuff position, but also the throwing position. You want to do biceps labral complex testing. I could give a whole talk on all the tests for biceps labral complex. Obviously, the active compression O'Brien's test is one that's used. The throwing test is one that's used. The biceps active test. So a lot of different tests that you can do trying to see if that biceps labral complex, whether it's where the labrum is attached, whether it's where the outlet it's coming out, or in the biceps groove, are the problem. You also want to do instability testing. Obviously, instability is less common in your pitchers, but it's much more common in some of the players that might dive back to a base. And then internal impingement testing, which is in that abduction external rotation position, and seeing if they have pain as opposed to apprehension, which is more of a sign of subluxation dislocation testing. In terms of the elbow, these are some of the gold standard tests that we do. Everybody that thinks about the elbow in a baseball player first thinks the Tommy John. Just to point out, the moving vagus stress test is the most sensitive and specific test. I usually will do an assortment of different tests. It's important to get the shoulder locked out when you're doing elbow testing, because if you don't, then you'll often rotate through the humerus and you won't get a good test on the ligament itself. It's very hard to really see instability of the elbow when you're testing it in terms of eliciting, a couple millimeters of increased opening. The reality is when people dislocate, you can sense that, but when from a ligament perspective, really it's hard to assess that. But these are the tests that you can use. But the moving vagus stress test has been found the one that's most sensitive and specific. So in terms of other tests, posterior medial impingement, there hasn't been a study done on this, but really you want to get them into a valgus stress, forced terminal extension, trying to get that osteophyte to hit up. Usually you'll see that with older throwers that have been potentially insufficient with the UCL for longer. You want to test for flexor pronator symptoms. Typically, flexor pronator strains are common, but flexor pronator injuries with John ligament injuries will usually occur in older athletes. And we did a study kind of denoting that, typically over 30-year-old athlete situation. You want to assess the nerve. Are they having any pain from the nerve, from compression or traction, sensation or weakness issues, or even subluxation? Often we'll do ultrasounds with dynamic ultrasounds evaluating if there's subluxation, because we want to know that, especially if we're going to surgery. You want to palpate the Electron, potentially do percussion to see if Electron stress fractures, and then obviously a lateral elbow assessment, looking for any locking or catching, and if they have potentially a capitellar OCD, which in throwers happens, but often you're not seeing them as commonly as you are some of the other problems in the elbow from a baseball pitcher perspective. In terms of the thrower's evaluation, then we go to the radiographic exam. You want to get typical shoulder x-rays. Often I'll see that x-rays aren't obtained, and it's important to obtain them. In younger throwers, you can see throwers' Hill-Sachs lesions occasionally. You can sometimes see calcification at the posterior inferior glenoid consistent with the Bennett lesion. So there are important things to be able to see that sometimes you won't pick up on an MRI as well. And then obviously the gold standard for testing when you need it is a MRI arthrogram or an MRI of a certain quality image. And usually I'll minimum get a 3 Tesla. I often do get arthrograms in the shoulder unless I'm not very convinced that there's a significant issue. But the thrower dilemma here is that if you want an excuse to operate on a throwing shoulder, and I know Dr. Saper believes in this because we trained with the same person, Dr. Andrews, if you want an excuse to operate, get an MRI. And so I often try to delay MRIs because there's going to be findings. If you have a high level of enough thrower, you're going to have findings, then you got to talk away those findings to convince somebody not to go to the operating room. And so often I try to delay for as long as possible. In terms of the elbow, here's a series of x-rays I get. I will get all these x-rays on a thrower's elbow. The oblique axial is extremely important to look for osteophytes, especially in older throwers. So usually you'll see an osteophyte in this location out here. But it's important to get all these views. Historically, there would be bilateral stress views that would be obtained with x-ray, and you'd look for joint space opening on the contralateral and the throwing arm. But now we're using dynamic ultrasound, which I have found great to be able to use because you can not only evaluate the opening of the joint, here's the ulna and here's the humerus coming up to where the attachment of the ligament is coming down there, but you can see opening in the joint and the fact that it opens up more with the stress ultrasound, but also you can see subluxating ulnar nerves. You can try to get a sense if there's any calcifications in the ligament and where the quality of ligament is porous, but also that dynamic ability to show opening is important from my perspective. And so often before I take people to throwing, unless they have a complete tear and it's clear on an MRI, I'll get a dynamic ultrasound as well. Often we see other things in addition to the UCL, but from an UCL perspective, this is a normal one in terms of what it looks like coming down. This is a partial tear on the humeral side. You'll see this undersurface changes. It's always harder to see the humeral side than it is to see a partial tear on the ulnar side. Here we can see the classic T sign or tau sign, which you can see the T, and this is the long part of the T. But you have a partial tear here, and here's a complete tear where you'll see here's the ligament, and you see fluid extravasating underneath all the way out into the muscles underneath the flexor pronator. And so that's a complete tear. So much easier to visualize on the distal side, which is at the sublime tubercle, than the proximal side. And these are some other things you can see, as I talked about before, that combined injury in the flexor pronator. You can see here's the flexor pronator with the ligament, and it's completely off. This person was injected several times before. That's why I don't like steroid injections in throwers in the elbow, especially around the Tommy John ligament. We can sometimes see these posterior medial osteophytes on this medical image right in here. Here's the Electron and the humerus right here. And then we can sometimes see Electron stress fractures where this one's in the ulna, and you can obviously, well, the Electron would be in the ulna, but that said, you can see a stress fracture here when you can do some digital windowing from the x-ray to be able to see it better. So remember, there's other pathology that you can see. Now we get into different problems. Here's the shoulder problems that you can see. So there's a lot of them. But what's common is common, and that's what we'll talk about here a little bit about slap tears, partial rotator cuff tears as part of internal impingement. And then especially since a lot of us on this meeting are interested in kids, little league or shoulder we'll talk about, which is also known as proximal humeral epiphysiolysis. And so from a throwing shoulder perspective, slap tears were first discussed by Snyder. There's a multitude of different slap tears and types of slap tears, but really it's an injury of the biceps labral complex. It can happen through a lot of different ways. Acutely, it can happen with weightlifting, but in overhead throwers, we see it more commonly. And it's important to understand, is it a good or bad slap tear as we start to learn about it. And so from a slap injury treatment perspective, obviously you can see here Ryan Zimmerman doing some WD-40 on his shoulder just to keep it lubed up. But often when that doesn't work, sometimes surgery is a possibility. But I try to keep every slap tear out. And what you want to understand from an MRI, as well as the symptoms, do you have a good or bad slap lesion? Because a lot of throwers will have slap lesions, especially if you've played for a long period of time. And so sometimes that rotational effects of the superior labrum can help and assist with throwing, but at some point it becomes bad and pathologic where you have too much instability and mechanical symptoms. And probably that's related to the biceps just as much as anything else, the biceps getting outlet instability that results in pain. And so how about the rotator cuff? Well, it's important to evaluate the rotator cuff as well, which we'll talk about. You can get obviously impingement and tendonitis. Often in these cases, something like a steroid injection will help elicit symptom resolution. But also you can get partial tears, and partial tears can come in many different orientations. They can come in actually avulsions off the footprint, and they can also come in situations where they're intratendinous. And then obviously full thickness tears are relatively rare in younger individuals, but also tears in a adolescent age are extremely rare. The goal is to figure out, how the rotator cuff keeps the shoulder balanced. And if the rotator cuff is weak or torn, then that can throw off the balance. So it's important to have an assessment for that as you're dealing with these throwers. And just remember, not all rotator cuff tears or repairs are the same. So often we try to keep these patients out of the operating room, especially throwers as well, but not everyone looks the same and not everyone will act the same. And so just like I said before, this is a partial tear that you can see under surface. Sometimes you get in the operating room and you can see fraying like this and partial tearing, which doesn't go into significant depth, but usually we clean up and we're conservative about, but sometimes you have to repair it. And it's so important to characterize the rotator cuff tear, again, because often if you're cleaning it up or you're repairing it, then there have been concerns from a repair perspective in terms of getting athletes back to play. So usually what people have thrown out is over 50% in a thrower. You repair it, under 50% you don't, but certainly that's also controversial. Now, as part of the rotator cuff and the slap world, you have this concept of internal impingement, and really that's when your arm is in abduction internal rotation. What you do is you get the posterior superior glenoid and the rotator cuff hitting up against each other, and you'll get changes that occur over time. And sometimes you can get this thrower Hill-Sachs lesion. Actually saw a kid this morning with that, had a huge thrower's Hill-Sachs lesion, was actually read on the MRI as a dislocation event with a thrower's Hill-Sachs. But you'll get kind of a buttoning of the glenoid causing a divot in this back area. That's what internal impingement is. It was described actually in France, where they don't have as many baseball players. How do we know that? Because they've decided not to hold the Olympics there in 2024, which is unfortunate for all of us. But the reality of it is you can get pathology in all three of these areas when you get the arm into position. So what are the outcomes with slap tears? This study was great, and it was done by Houston Methodist, and it was done by the Astros team physician. And what they looked at was return to play, as there was limited data on non-operative treatment. They published a series of overhead athletes that showed 66% were able to return to sport with PT and NSAIDs. And professional pitchers who failed initial PT were sent for surgery again. And over the second course of extended rehab, another 40% were able to return to play. And so you were able to, if you were patient with these athletes, you were able to get good success in returning people to play, but it might not just take your typical 6 to 8 weeks of time in non-throwers that we see. And so what they found was this: return to play, non-surgical, was 40% in pitchers versus position players were fairly similar. But from a surgical perspective, you can see there much less in position players than, or much less in pitchers than position players. And so that was after the second round of failed PT. But what's interesting here is in pitchers, return to prior performance was much even lower, 7%. And so it's so important to get an understanding of, there's not only just returning to the mound or returning to the field, but are you able to participate at the same level? And so often our success rates are a lot higher in non-surgical management, but in position players, you have more success after surgery than you do after no surgery. And so why don't all slap tears, especially in throwers, do well? And so this is something I've thought a lot about. And number one, is the slap the only symptomatic issue, or are they having other breakdown issues? And I think this is often what the issue is. You have scapular, rotator cuff weakness, poor mechanics and such. And these are important factors to contribute that a lot of times you just don't spend enough time on. Number two, the slap is not the problem itself. So what else was the problem? It could be a biceps problem. This concept of biceps outlet instability, biceps traction pain, incarceration of the joint in that position. These are all things that I think we need to think more about, just because slap tears itself, after you operate them, don't predictably do what we want them to do. The rotator cuff tear. Often what we found in different studies is the rotator cuff tear can be predictive and prognostic just as much as the slap tear. And then, is it a poor repair? Could we as surgeons be doing a better job? I think with technology, we have the better ability to take care of slap tears and try to get them to heal, but it's a fairly avascular area that doesn't like to heal. And so often, even if you get it to heal, do the sutures bother people? And so a lot of different things that could affect the thrower even after a successful slap repair. And so this is the part about the rotator cuff. With SLAP outcomes, if you add the rotator cuff to it, we can see that with pitchers with partial tears, return to prior performance or return to play was 33% with surgical management, but 0% with return to prior performance. Now, only 9 athletes in that series from Houston, but still, again, we need to be very reluctant to take these athletes to surgery. But when they do fail, we just need to be realistic in the beginning. What I tell them is before we operate, I'm realistic. After we operate, I'm optimistic. And so we need to all be encouraging afterwards. But again, I think the goal here is the SLAP tear itself we'll find, and sometimes can be adaptive, but I think we need to be very slow to operate on them because often there can be other problems that are actually causing their pain and inability to throw. So I'll just briefly talk a little bit about little leg or shoulder. Obviously, if the growth plate is open, that's the weak point. And so this was originally described in 1953. It's kind of been thought of as a stress fracture. To me, it's kind of overload of the proximal humerus growth plate. And so I've even seen Salter-Harris fractures called and things like that when you have widening. So I think it's just increased stress in the growth plate, and the growth plate does not like you very much. And so I have seen situations where human growth hormones, some athletes taking that, and or medications keeping the growth plate open sometimes worry me. I had a kid that actually fractured, went back to play, was asymptomatic, and actually fractured as well. And so I often think that those medications can make people more susceptible to further injury. And so often I'll be much more conservative in those cases. This is described as average age of 14 in studies, gradual onset of pain, localized at the proximal humerus. Average duration of symptoms can be up to 8 months. And so usually you'll have patients that are tender over the physis. They'll get pain and extremes of motion, especially in rotation, external, internal rotation, when you're kind of torquing through the growth plate. And so they'll possibly have discomfort with resistant testing. So it's important to evaluate the x-ray and know that the growth plates are open and that this can be a source of potential problem. You can see on the left image, we can see widening of the growth plate as compared to the right image in a non-throwing shoulder. So you can see great changes here, and those changes did not occur when the athlete was having symptoms. They probably were occurring before that, and now the athlete's just having pain because they're getting those findings of demineralization, sclerosis, and fragmentation sometimes around the metaphysis area of the growth plate. Now, I love this picture. This is actually my son right here, and you can see he's not on the tallest side, but you can see some of these kids at this age, how different they are. Obviously not the coaches, but we can see here kids that are different sizes, different shapes, and so that's why it can really be humbling because every athlete is probably not the same when it comes to this age group. But this was a study that was done by Carson and Gasser, just basically saying how long sometimes these athletes can take to get back to play. Often I try to keep these players on the field. So I'll try to get them designated hitting or being an extra hitter. If I can get them to first base then subsequently, then you try to get them to first, play the right side of the infield, trying to keep them on the field playing baseball around their social environment, but also protecting their arm from worsening problems. And so it's important to know that we can get athletes back successfully, but that doesn't mean that every athlete's able to get back to pitching, especially in a short period of time. So I'll briefly go over some of the elbow injuries here. I'm going to talk about Tommy John initially. Just know there's tremendous forces about the elbow. Age does matter. Growth plate is weak early on. So if they're less than 13, think the medial epicondyle, little leaguer's elbow, possible avulsion fractures. You can see images like this where you get a little bit of widening at the top. When you get to 13 to 15, you got to think about both because sometimes they'll have delayed closure of the growth plate. Sometimes the growth plate will still be an issue, but they'll start having ligament issues. And you can see here still residual opening in a 15-year-old, but probably at some point had an avulsion of the ligament in the past. And in fact, this kid had something at 11 years of age. Over 15, I start thinking more about the ligament itself. Also, it's important to think about acute versus chronic. They've been having chronic symptoms, probably more little leaguer's elbow. If they have an acute pop, then you got to think about the medial epicondyle pulling off. And so the biggest question comes is, do you screw it or you do not screw it? And the reality is in throwers, less than 2 millimeters, then I have a conversation with them and I'm likely to keep non-operative. 2 to 5, then I tell them either way. And then over 5, I encourage throwers to definitely have surgery for that. And it depends on the characterization of what the ligament looks like. I'm more often to get MRIs on some of these now, just looking at the quality of the ligament and look if the ligament looks lax. But I'm also sometimes getting dynamic ultrasounds as well. So non-operative reports are rarely reported. It's all over the place. And honestly, it comes down to how patient people are. often the younger you are, the more non-operative should be there. The less of a complete tear, the more you should be non-operative. This study done by Schickendance's group at Cleveland Clinic was phenomenal. And I know this is pretty wordy right here, but what it shows is that if you have a distal tear, much more likely to fail non-operative treatment. So this has really gone into my treatment algorithm now in terms of talking to families and athletes about it. About this is another prognostic thing. If it's a distal tear, complete tear, they probably need surgery. If it's a distal tear, partial tear, I'm just a little bit more. I'm still do non-operative treatment, but I just counsel them appropriately. Often I see people in second opinions, so they've already had partial treatment, and so at that point, depending on how partial the treatment's been, sometimes I'll be a little quicker to operate if enough times go by. But often, the younger you are, the less I like to operate. The more distal the tear is, the more that I am a little prognostically concerned about them doing well. Obviously, there's two different surgeries now. A lot of us have heard about reconstruction versus repair. I'll just talk briefly about them. This is a study that was initially done by Job, about 68% return to play with reconstruction. I just wanted to show this UCL operative trend standpoint. Over 50% of all Tommy John surgeries right now are getting done in people between the 15 and 19 years of age. And so obviously, now that it's become a good option to get people back to play, I think sometimes we're overshooting here. But obviously, this young age group, we're seeing more and more surgeries. And why it's starting at 15 is because that's usually when the growth plate's closing. And the ligament has been the issue at that point. Return to play and return to normal. Those are two things I want to point out as you're getting back from Tommy John surgery. Often athletes will go 12 months and they're getting back. With repair, it's less. But return to normal, I always tell them that first year is their year to kind of help get back into their elbow, per se. This is the results that have been shown for reconstructions. A lot of data showing about 84% return to play. Most of the complications are transient and related to the nerve, but really good results over time. This is a study that we did, a long-term study, looking at long-term results and getting patients back to play. And we find, and honestly, what was apparent to me was how many people continue to play baseball even if they're not playing competitively. And often Tommy John, they were still doing well from a longevity perspective, as well as with non-baseball related activities. And so that's just the one thing I wanted to point out here, that with Tommy John surgery, usually long-term outcomes are good. Repair is the other thing I wanted to point out, just going back to Job. He did describe a repair cohort and 50% return to play. And so if you look at that, 50 and 68% weren't that far off initially, but we kind of threw the baby out with the bathwater and basically just turned to reconstruction. And over time, repair can be a good option. And why? Because not all athletes have poor quality tissue, and especially these young and adolescent athletes, usually they're less, the ligament's less injured and less deficient in tissue. And usually it's more avulsion type injury issues off the sublime tubercle or the humerus. And so to me, that means in this population, UCL reconstruction with adding graft for poor quality tissue is probably not needed. And in fact, studies have come out, this was Buddy Savoy's, even before the internal ligament brace, that showed great success in young athletes with 93% return to play. And then Jeff Dugas has really pioneered this with UCL repair with internal ligament brace and showing great results when you do this as well. If you have good quality ligament that starts on the humeral or the sublime tubercle side. So again, repair can now be a great option for some of these athletes. I only have a couple slides on Electron stress fractures just to talk about. It's important to have a location-specific risk stratification and treatment protocol. This is the one that we wrote up in a book with John Conway, just talking about the ones we see in the young people are these adolescent electron apophyseal stress injuries, but also you can get stress fractures that are manifest stress reaction on MRIs, or true stress fractures that can be on MRI or on ultrasound, on X-ray as well. This is the one study that was done by the Andrews group as well, looking at you can have successful return to play after electron stress fractures with 100% radiographic union and 94% return to play in this cohort. So again, stress fractures can be one of these things we see in these young athletes as well with successful return to play. And so the last thing I'll lead everybody, and hopefully I was at least semi on time here, that this is the world of baseball players. And for everybody I've talked, they're forever your patient until they retire. And even when they retire, they're not truly retired. And so I love this quote by Hugh Tillis that came out in 1983 that said, "We do not fix them, we only temporarily improve them. If they continue to pitch, they will continue to have their problems sooner or later. And so I think this is important. Yeah, I have patients that are lifelong patients that are throwers. All right, I think that's it. But thank you very much for giving me the opportunity to talk, and I'm looking forward to the panel.
Thank you so much.
So if the panelists for this session can make their way on, hopefully you all can see my screen.
Yes.
So we've got a nice panel. Because of the PowerPoint I have, I don't see specific questions because my chat's hidden. But we've got a few minutes. We can. I'm going to try to get through a case. Certainly, if there's a specific question about Paul's talk or Dr. Osbar's talk, if you can either just speak up to ask it or put it in the chat to the speaker. Hopefully, they can type it in. But we've got Paul and Daryl both available as well. Dr. Krayback, I believe he is on, and then Steve LaPlante, I don't think got his introduction. So for Budo and O'Brien, he's one of our primary care sports medicine docs and one of our specialists in ultrasound evaluation and PRP, and we'll go over a case involving that. And then Steve LaPlante is a physical therapist at Andrews Institute Children's Health in Plano, Texas, and he had worked with Dr. Andrews in Florida, and I was able to work with him a little bit during my fellowship. So we've got a nice experienced group to kind of hash out some of these scenarios. So this first case is an 11-year-old right-handed boy. He has some elbow pain. He pitches, he also plays infield. And the injury that he reported, he was actually pitching. He was a mid-reliever on the second inning of work and had a medial pop on his throwing arm after throwing a fastball. He was about 20 pitches in. He was able to continue pitching before he had to stop. Mom noted that he was throwing maybe harder than normal and maybe a little bit quicker. Had some soreness for a few days and then stopped throwing. Some of his baseball history, he does play year-round on one team, and then he, like many kids, is on the second team that he does during the spring and summer months, and his typical fastball is around 55 miles an hour. His exam, medial tenderness on the primarily around where the UCL is, but just don't have the specifics of exactly where, whether it's proximal, mid-substance, or distal. He does have pain with the moving valgus stress. His motion's relatively normal. And so this kid gets advanced imaging done, and if Brian's on, if he could just kind of take, since this was his case, if he could just take us through what you were seeing on the imaging here.
Yeah, so this is the kid, and here you can look at the MRI. I think Dr. Osbar actually pointed out some of the key components here. So proximally in regards to the UCL, you could see fluid around the UCL and build up through there. Originally read as a full thickness tear. This kid had actually seen someone else in consultation before they made it to Seattle Children's. And it had been recommended that he undergo surgery to kind of repair this because some of the non-operative treatment was not working. But probably to draw your attention to not just the proximal component of the UCL, but the distal component, which I think Dr. Osbar talked about, with some fluid going in there. And there was concern towards that subline tubercle. And Michael, you might have to actually point. I'm not sure if people can see what I'm talking about. But you could, yeah, there you go. I was concerned that had lift off there and that there was perhaps disruption of the ulnar collateral ligament in the more distal segment of this that was of subsequent concern, and that was not pointed out in the initial report of the MRI.
So now we think about treatment plan, and Dr. Krayback mentioned that this patient, kind of presented, he kind of failed non-operative treatment. Certainly, a question I have, and I think a lot of people have, is is what is failing non-operative treatment. So I'm curious if Stephen can maybe comment on what, his thought process, and maybe, both Steve and Paul can talk about if on the PT side they're given that information, or do patients just present with a UCL tear and then you guys have to go digging through where the tear's at, what type of tear, or are you getting specific information that helps you with your rehab?
Yeah, I'll take the lead on that. We're pretty fortunate, and Dr. Saper, kind of Dr. Andrews' motto is to provide as much information to the therapist as possible. So I usually do know a lot more about what's going on. Just having that connectivity to our, we work with like Dr. Meister and some other guys in the Dallas area, and they're really information. For me, I know like the rehab is pretty standard regardless. Restoration of normal motion, range of motion, going back to strength. But the key to all these, and I think this has been presented numerous times in this talk, is that this is a global problem. So you could go and attack the kid's elbow and his shoulder, but if you're not addressing the core and the lower legs, like this kid's just going to continue to be injured and probably blow that thing out.
Mm-hmm. Daryl, and I'll mention in a minute, and you brought up in your talk, tear location matters. When you see that MRI, do you mentioned that you will send people to PT. Maybe you're not optimistic that it's going to work. Are you, in this scenario where they present to you as maybe a second opinion when they quote failed PT, are you offering biologics? Are you going straight to repair potentially because it's distal? What are your thoughts on management at this point?
Yeah, so I love that statement, failed PT, because I think that's a huge problem that I see is that people check a box with PT. And so I can't tell you the number of times I am actually sending somebody in second opinion to one of my trusted physical therapists who knows baseball medicine and understands it, and getting their opinion on if somebody truly failed. So it's amazing. Some kids that have done 6 months of PT and their rotator cuff's still weak, their scapula's all over the place, and so I just wonder how much they've done. And so for me, I do have a concern in this athlete, especially their medial epicondyle growth plate's open and they have a distal tear. And so to me, I wonder, how does that happen, right? Just because, the growth plate should be the weakest point, but certainly this person was loading that sublime tubercle attachment site more. And so I think one day we're going to be smarter as a profession, understand how they're loading that side versus the epicondyle more for the proximal and distal tears, just because that should not happen theoretically from a science perspective. When somebody feels a pop, it should have been the medial epicondyle. And so for me, I would almost rather have a medial epicondyle fracture I'm fixing right now than the distal part of the ligament part. And so I think for me, that's the concern I have. I think from a PRP perspective, yeah, I think that's the one thing you could throw at them. The problem is, and we did one study years ago, you might know about, there's been probably 3, and in professional baseball, even a analysis went and said PRP didn't make a difference. Now with the young people, I would tell you, I would offer it out to the family. 11-year-olds, we should try to keep out of the operating room. We have no idea if that kid's going to be playing when he's 15 or even 18 or what have you. So I would make sure that I've offered them everything to keep them out of the operating room. And then when they fail or they don't do well, then I think surgery here, I would be going for the distal ligament and repairing the distal ligament, not doing internal ligament brace to mess with no growth plate, right? I would just be repairing it back to bone, kind of Buddy Savoie perspective if I had to take to the OR.
Brian, you did offer biologics to this kid. Can you just quickly kind of take us through that thought process, the counseling, maybe some of the findings that you see on ultrasound that maybe would make you think that PRP would maybe have more of an effect?
Sure. I think I agree with all the speakers. I think this is the key. He's a young kid. He's 11. It is a bit confusing while he had the distal versus the proximal. So we sat down and basically, again, talked about what was your rehab? Are you really just not progressing, and felt that he had actually gone through what was an appropriate rehabilitative protocol. Because of the MRI finding, we looked proximally and that looked pretty good, but then followed the ligament distally towards the a subline tubercle, so kind of where the arrow's pointing towards that bump right through there. Followed it more distally, which can be really challenging. And I think as you can look at this, you could see there's an area that looks somewhat black towards that attachment. And this is quite an interesting anatomically because the ligament comes in, the pronators or sort of flexors are attaching through there. So there is a complexity to that. But it was felt that the ultrasound, as you can see here, showed an area of deficit or tear through there. So then we talked about the role of PRP, which this family was quite interested in for a variety of reasons. And normally when we talk about that, we'll talk specifically about the fact that, first of all, this is not well studied within this age group whatsoever. We talk about the important component of this is that it's not a quick fix, right? This is going to take months to kind of go through and needs a proper post-procedure rehabilitative program to make sure that we don't load the tissue structure too much, and that it can take, you know, a good 3 months before we're really kind of seeing where things are going. Interestingly, I've done PRP in various areas for these adolescents and younger kids, and they actually seem to recover quicker, and that's anecdotal. I don't have a good great study on it as much as when we've done that. So when we viewed this, we saw that and wound up doing the procedure with PRP, which he actually did phenomenally well. It's a very uncomfortable procedure for anyone who knows when you inject the tendon. And then for post-procedure, usually we'll just put them in a sling just for comfort and gentle activities to daily range of motion. 6-week mark. So the first, gently just working on range of motion, not overloading that tissue, letting the biological process happen. And then if they're progressing nicely, then get them back into physical therapy in regards to that load management protocol. And then this kid basically over what was, well, what's your slide? Let me make sure. Trying to remember what data you have in there. There you go. Sorry, just that. For this kid, we wound up really just taking a little bit more closely in regards to follow-up and on a monthly basis. And really, it was sort of the first month was of just kind of managing the soreness, working on areas around the elbow itself to make sure they're optimized, and then progressing more towards a incorporation of that kinetic chain. And for this kid, by 3 months, he was starting to really start returning to throwing a baseball, and by 4 months was ready to go. Unfortunately for him, COVID hit, and that just kind of canceled the whole full return. But overall, I think he would have been quite successful in getting back, and a great opportunity for being creative and thinking about non-operative management for a unique case.
Yeah. We're kind of time. I wish we had more time to discuss. I just wanted to briefly point out, and Dr. Osbar mentioned, some research. He was part of this study, but if you look at the high school athletes, and the mean age, this is a different group than this patient, and I think we need more research looking at the use of biologics, period. But we certainly need more research looking at the utility of PRP for these tears, whether it's partial. Or whether it's proximal or if it's one of those complete distal tears, because an 11-year-old, 13-year-old certainly different anatomy than a 17-year-old, and maybe better results than this study where it showed that 100% of these ulna tears failed. So as was mentioned earlier, we have to really kind of dig into the methodology and the details of these studies when we're basing treatment options. But I think, at least to start, I think, a nice case of going against kind of the grain, so to speak. But I wanted to thank the panel. Again, apologize for the brevity of this session, but learned a ton. And I'll turn it over to Tara for any closing remarks.
Yes, I just want to say thank you to all of our speakers and everyone who joined for our panel today. I think today was another wonderful symposium, great content. If anyone does have any follow-up questions or anything, please feel free to let me know, and I can, get you in contact with whoever you have the question for. Please take a look for the survey to hit your inbox so we can get more information for our next symposium. Our next is May 11th. We will have those invites going out, but everyone have a fantastic Wednesday, and thank you for joining us today.